Thank you, Dr. Verenga. I'm sorry for the delay. I was having challenges with my Zoom. All right. Good morning, everyone. I'm Dr. Dzveya, Junior Registrar in Obs and Gyn, currently attached in Fetal Medicine Unit. So today I'm going to take you through two cases which we managed at Fetal Medicine Unit at Salem Kabe Hospital. So the first case, so let me put it the slide. Sorry. All right, so I think we are fine now. So the first case, so for the purpose of this presentation, I'm going to call this patient Miss PM. So this was a 24-year-old patient who was in her first pregnancy. We saw the patient at a gestational age of 19 weeks plus 5 days, and estimated gestational age, estimated date of delivery was 14 June 2024. She was not sure of the last normal menstrual period. So she's actually a housewife. So she came to the specialist clinic after she was referred from Red Cross Radiology for hernia. So the background of this pregnancy, it was a planned pregnancy. However, there was no preconception care. So this patient could manage to get a preconception folate. So she conceived naturally and booked the pregnancy in second trimester. The exact gestational age was not clear. She booked it local clinic. So because of the late booking as well, there was no first trimester ultrasound scan, which was done, which would expect to be done between 11 weeks and 13 weeks plus 6 days. And she was not offered any torch screen, and aneuploid screening was not done as well. And this patient does no any other history of medical illnesses such as diabetes mellitus, epilepsy. She didn't have any exposure to teratogenic drugs, as well as recreational drugs as well. In a family, there was no history of any congenital abnormalities. The marriage, there was no consanguinity in that marriage as well. Systems review was actually unremarkable, and obstetric, it was a first pregnancy. Gyn history, there was nothing of note in the gyn history. Then on examination, she was late. She was late, pink. There was no respiratory distress. Obstetric examination was actually essentially normal. Also, the rest of the systems were essentially normal. So, in summary, I've presented a 24-year-old patient who was in her first pregnancy at a gestational age of 19 weeks plus 5 days. We had been referred from Red Cross Radiology for hernia. So after this, so that's what we always do in fetal medicine unit. We try to take the history first before we go on to scan the patient. So after this history, we then went on to scan the patient. So all right. So from this image, this image was actually done at 19 weeks plus 5 days. And it's actually showing that, let me put a case, sorry about that. Let me try to look for a pointer. Okay, this one. Sorry for that. point. Okay. So, okay. So this image is actually showing that there is acrania here. You would see that this cow bone is actually missing there. This is just a fluid, the brain tissue. There's a little of brain tissue here. So, so normally these cases are supposed to be diagnosed in the first trimester between when we do the first trimester scan between 11 weeks and 13 weeks, 6 days. But because this patient couldn't manage to get the scan, so the diagnosis was actually missed until there's now there's sort of like autolysis of the brain tissue due to the exposure to amniotic fluid. So this is a case of acrania. And also, if we go to the spine, you'd see that this spine is not the usual normal spine which we expect to see. You'd see there's actually distance from the skin into the spine. This is a large distance there. And if you look at them, vertebra, you'd see that towards the end, these vertebrae, they don't look that normal. So, so this case probably there was also an associated myelin also from this. So the next image. Okay, so this were the other images which we saw on that patient. You'd say that this is an image which is showing in omphalocele. So this is the usual plane which we use when we want to take the abdominal circumference. You'd see this is the vertebra, the rib there, and also another rib here. So, and we have the stomach as well. So you would see that instead of getting a nice AC here, you'd see that there's a protrusion of this mass there. And there's also a layer which is covering this. There's a membrane which is covering this mass as well. So this is actually in omphalocele rather than a gastroschisis, which there's which the loops of the intestines are actually will be freely and there's no membrane on that. So, and you also see in this picture as well, there's a large defect. This is the defect here. You see it's about 20 millimeters. So the next picture. So this picture, there's a color Doppler here. We try to interrogate with color Doppler here. You also see that there's inclusion of the liver in the omphalocele sac here, and you would see, and also you'd see these are the umbilical cord. You see this is the umbilical cord. Normally, it's supposed to be inserted at the tomb of the omphalocele, but in this case, it's actually on the side of this of the omphalocele. Then the other picture on the right, on my left, sorry, this picture, we were interrogating with the Doppler as well. We wanted to see whether there was the heart also included in the sac here, in the omphalocele sac. You see there's a gap here, which means the heart was not actually included in this sac as well. So there was no ectopic codex. So we'll move on to the next picture for this. This picture actually demonstrates that there was a cleft lip, and also there was a cleft palate, and also a cleft lip as well from this picture. So in terms of this, in terms of the further management after being faced with this patient without brain, so this patient received extensive counseling from the fetal medicine specialist from Dr. Erenga, and also from the professional counselor, which we have at the fetal medicine unit. And also offered the patient a touch screen if she couldn't have funds for the test to be done. And amniocentesis was actually offered to the patient, but because of the funds, nothing was done. So in terms of the definitive management, we offered the patient a termination of a pregnancy, as well as the conservative management, so that the patient will then decide which management she wants to take. So I followed up with the patient. She told me that they are still deciding on further management. So the pregnancy now is around 23 weeks. So they are still deciding. Then, so after facing this scenario, we then went on to try to check on OMIM, the syndrome of this, as we know that approximately the omphalocele is actually associated with genetic syndromes in about 30 to 50%. So we tried to check on OMIM was the genetic syndrome for this one. So to then, okay, so from the list which we're looking at, we thought it was more in keeping with the short rib thoracic dysplasia 2 without polydactyly. So this is actually a group of diseases which are autosomal recessive skeletal gliopathies that are characterized by a constricted thoracic cage, short ribs, shortened tubular bones, and a trident appearance of the acetabula. The trident appearance is more like a sort of like a fork-like appearance, the acetabula are rough. So the short rib thoracic dysplasia, it actually encompasses the other syndromes such as the Ellis-Van Creveld syndrome, and the other syndromes like Jones syndrome, which was also called as asphyxiating thoracic dystrophy, and short rib polydactyly syndrome, and Mainz Sydeno syndrome. So it's actually a group of disorders such as that. Then this disorder also include the non-skeletal features such as cleft lip palate, like in our patient, she had cleft lip palate, and also other major anomalies in other organs such as the brain. The patient had more often anencephaly picture as well. And also the other organs such as the eyes, heart, kidneys, liver, pancreas, intestines, and the genitalia as well. Some of these short rib thoracic dysplasia, they're actually lethal in the neonatal period due to the respiratory insufficiency secondary to severely restricted thoracic cage. So, and as of our patient, because this is actually it's a variable disorders. So in our case, she actually had the one which is more lethal because the brain was not existing. So definitely in that case, the best option was just to terminate the pregnancy. So the short rib thoracic dysplasia is caused by a homozygous or compound heterogeneous mutation in the intraflagellar transport 80 gene, which is found on chromosome 3, on long arm of chromosome 3, region 25. So in terms of the clinical features, you would find that the patient would have frontal bossing, mandibular hypoplasia, low set ears, atretic, external auditory meatus, cleft lip, cleft palate. So those which are highlighted in red are those which our patient actually are the features which our patient actually had. And then also a short neck. In terms of the respiratory, sometimes you might have a bilobar right lung or unilobar left lung, narrow thorax, short ribs, wide ribs, squared scapulae. Then abdomen, you can have omphalocele, which our patient also had. And in terms of the genitourinary system, you might have a multicystic kidney or a multilobar kidney as well. Then in terms of the skeletal absence, cranial fold, which our patient had, and you might also have trident acetabular roots, platis spondylae. These ones, they are sort of like flat vertebral bodies, which are actually spaced. So our patient, I think if you look at that picture with the first picture which was showing the spine, you'd see that towards the end the thoracic vertebra, the vertebra was actually spaced towards the end. Then you would also find about femur, mesomeric limb shortening. This mainly involves the bones such as the ulnar and radius. And for our patient, the limbs, the femur, they were actually within the normal limits. And you can also have rhizomelic limb shortening. This is mainly the femur vertebralis, but in our patient, it was actually within the normal limits. Radio aplasia, fibular aplasia can also happen in this. And you can also have polydactyly post-axial. This is when there's an extra finger on the little finger. That's when you can, that's polydactyly post-axial. And you can also have small feet, talipes, equinocaria, that's club foot. We can have syndactyly as well. Then in terms of the neurologic, you can have anencephaly, and which our patient also had. So in terms of the prognosis, this is actually a lethal condition. So termination of pregnancy is usually offered upon diagnosis in detail. So this is our first case. So I will move on to the next case. So the next case, this case was a 22-year-old was in her first pregnancy again. And when we saw the patient, she was at 33 weeks plus 4 days housewife. And she had been referred to the specialist clinic for polyhydramnios and absent stomach. So on background of this pregnancy, it was actually a planned pregnancy. However, there was no preconception care, so she couldn't get folate preconception. And this pregnancy was conceived naturally and booked in the first trimester. However, the gestational age at working was not really clear. She received imatinib, including folate debulking. However, this was actually late because the brain tissue had already been formed. So she was supposed to receive this from the preconception period. So that first trimester scan was done, but there was nothing abnormal detected when the first trimester was done from other radiology center. Aneuploid screening was not offered, Tochi screen was not offered. She didn't have any history for diabetes mellitus, epilepsy, or any other medical illnesses. And she doesn't have any history of exposure to testosterone drugs or in recreational drugs. There was no family history of congenital abnormalities or connective tissue disorders. And in a marriage, there was no consanguinity. Systems review was actually unremarkable. Obstetric and gynecological history unremarkable. Medical and surgical history unremarkable. Examination was essentially except for the height of fundus, which was large for that dates. So in summary, I've presented a 22-year-old who was in first pregnancy with an estimated gestational age of 33 weeks plus 4 days. Housewife who had been referred to the specialist clinic for polyhydramnios and absent stomach bubble. So after the history, we then went on to do the ultrasound scan of this patient. So for this patient, you can actually see that the head circumference, it was actually the head circumference, it was less than 1%. It's less than 1% for the gestational age. So there was a microcephaly. Then, then if we look at the other picture as well, you'd see that there was a ventricular megaly. This one, the right and the left, you'd see the first one, this one, yes, this one, it was 14 millimeters. It was 14 millimeters. Then the other one was actually, it was 8 millimeters. So this one, there was a ventricular megaly. So it was because it was above 10. So there was a unilateral ventricular megaly. This one is the left. Then the next image, and also when we did this, when we did the head circumference, ideally you're supposed to see the cavarium here. There's nothing there. You just see these dilated ventricles. So there was also absent cavarium there. So we go to the next image. From the next image, you'd see for this one, if you look at this, there's no, the nasal bone is not present here, because we are supposed to see the nasal bone here, but it's not there. Then if we look at the chin is actually small. So there was a micronathia there. Then we go to this picture, the other picture. This is was showing the measurement of the cerebellum. You see the cerebellum was less than 1%, so it was actually small for the gestational age, probably due to the compression of the ventricular megaly. Then in terms of the Cisterna magna, it was 3.8, which was actually okay. Then we go to the next image. The next image was showing the limbs, the humerus, the femur, and also the humerus. So the femur, it was actually at less than 1%. So the femur was actually extremely short. And also, if we look at the humerus, you'd see that the humerus was actually 36.9 millimeters, which was at less than 1% as well. So it was extremely short. So this picture, we had rhizomeric, well, we had rhizomeria. That was the picture which was there from these limbs. So let's move on to the next picture. So the next picture is showing the radius and the ulna. You see that the radius, the ulna was at less than 1%, as well as the radius was at less than 1%. So there was a mesomeria. There was a mesomeria because these limbs were actually, these bones were actually extremely shortened. So we go to this image. So this image, if we look at this image, and this is actually the 3D construction of this, you'd see these eyes, there's proptosis of these eyes as well, although the actual eye is actually a little bit small, but there's a proptosis. And also if we look at the nose, from the earlier picture, we saw that the nasal bone was not present. So this is actually what you call proboscis, where there's just sort of like the thickened membrane, but the nasal bone is not actually present from this. Then there was a little bit of hypertelorism, because the distance between the orbits, it's actually a bit larger. So there was a little bit of hypertelorism as well. So we go to the spine. So when we look at this spine, ideally you're supposed to see that ideally the spine supposed to be sort of like tethering towards the end. But you see this, if you look at this, there's actually widening of the spine towards the end. And there was a little elevation here. So this is most likely a myelococele, this one, which is there. Then we move to the next picture. Next picture. Okay, so this picture is showing there's there's polyhydramnios here. The single diploid stipple is actually 108, of which the cutoff is 8. So there was polyhydramnios there. Then we moved to this one, a 3D construction. This one, see that there was a club foot there. You'd see this. And also there was also a deformity of this leg. You would see that where the leg is actually sort of like it's turning medially at right angle. So this is actually a deformity, which was also there on this picture. Then we go again to the abdomen, and this is the image which we normally use to take the abdominal circumference. You'd see that this is the vertebra, but you can't see the stomach bubble here. You can't see the stomach bubble. This image, it was actually, they were actually it was actually a repeated image. Initially, it was done, tried to check. At the end of the examination, they actually repeated again to check. Probably there's probably the stomach would have been distended probably after the baby had swallowed something, but the image still remained the same. So there was no stomach bubble. So because there was no stomach bubble, our another differential was actually esophageal atresia was one of our differentials there because of that. And so this image, you will try to look for the insertion of the umbilical cord. So it was actually inserted in the normal place. There was no gastroschisis. There was no omphalocele. Then we move to this. Okay, so this image is showing that this is the picture of the ductus venosus. And this ductus venosus is actually showing that there's actually a reversed A wave here. You see, this is the reversed A wave. So the ductus venosus of this patient was actually abnormal, meaning that the heart of this patient was actually struggling. So we then proceeded to do an fetal echocardiography. We noted that there was a double outlet right ventricle here. Instead of having a 4-chamber view, you'd see that there are probably about sort of like a 6-chamber view of some sort. And this is the double outlet right ventricle. And then okay, so in terms of management of this patient, the patient was counseled extensively in view of the defects which we noted during the ultrasound scan. And an OGTT was done, and it was unremarkable. Torch screen was offered, and patient couldn't afford that. Then amniocentesis was also offered, but because of the funds, nothing was done. Then she was offered termination of pregnancy and also conservative management of pregnancy. Then the couple opted for termination of pregnancy. So the paperwork was done, and we decided not to do the fetal side because we knew that this patient had a lethal condition and the baby was unlikely to survive. beyond the first day of life. Given this, the heart was already struggling as well. So she had the induction of labor with misoprostol, and the baby actually, the baby was born with breathing difficulties and deceased within the first hour of delivery. So according to the mother, I didn't quote the mother. According to the mother, the baby had a Mickey Mouse face, is what was shown during the ultrasound scanning. So we then went on to check on OMIM, tried to see which condition was likely. So we thought it could be this syndrome, which is a generalized connective tissue disorder characterized by early onset aneurysms of the thoracic aorta and other arteries, joint hypermobility, skin laxity, and hernias, as well as cranial dysmorphic features, structural cardiac defects, skeletal anomalies, motor developmental delays. And this syndrome is actually caused by homozygous or compound heterogeneous mutation in the importin 8 gene, which is found on chromosome or on short arm of chromosome 12 region 11. So in terms of the clinical features, you'd see that there is the head, there's a brachycephaly, like our patient had brachycephaly, where the AP, the biparietal diameter is actually larger than the AP diameter. So this is a case with our patient, and our patient had microcephaly as well. And there was a micronathia. In terms of the frontal bossing, yeah, to some extent. Then there's also abnormal facial shape, epitularism. Our patient also had epitularism, and there was proptosis. Our patient also had proptosis. Then the other features include diactive palate, bifid broad uvular cleft palate, which our patient didn't have. Then in terms of the cardiovascular system, our patient also had a VSD and a double aortic right ventricle. So these conditions in the cardiovascular, you can also find arterial septal defect and mitral valve prolapse, right ventricular hypertrophy, right ventricle dilatation, aortic root dissection, patent ductus arteriosus, aortic aneurysm. Those are the other features. In terms of the chest, you can have pectus excavatum, pectus carinatum, diaphragmatic hernia. Our patient also had diaphragmatic hernia as well. Then in terms of the abdomen, you can have umbilical hernia, inguinal hernia, other abdominal hernias, feeding difficulties, malpositioning of the stomach. So since our patient did, we thought that could be a possibility, since our patient did a diaphragmatic hernia as well. Then in terms of the genitourinary system, you can have hydronephrosis, cortical cyst, large cortical cyst, hydroureter. Our patient didn't have any urinary defects. Then in terms of the skeletal, you would see there could be scoliosis, talipes equinovarus, that's a club foot. Our patient had club foot. Would have evasion of the feet, which our patient also had. Then those ones, the neurologic, motor delay, those are more of a developmental. So So our patients, so in terms of the management of these cases, usually are supposed to collect a sample. Probably you collect, you do amniocentesis, or you can do colonic sampling. Then after that, you send the sample for chromosomal microarray so that we can get the definitive diagnosis in cases like this. So as a take-home message, that fetal defects are prevalent in our country. So you need to make sure that when you are scanning the patient, make sure you are scanning the patient as if you are the last one to see that patient. Otherwise, that patient would then have a baby with a defect. So let's refer all the cases with abnormal ultrasound scan, or those ultrasound scans which are suspicious, those ultrasound scans which we are not sure of. Kindly refer them to fetal medicine unit for further evaluation by the specialist. Then let's try to encourage our patients to have preconception folate, and to have preconception folate rather than to start the folate after they already conceived. Then you also encourage the patient to have a first trimester ultrasound scan between 11 weeks plus 0 to 13 weeks plus 6 days. Thank you. I will hand over the floor to the chair.
Thank you so much, Dr. Dzveya. Very interesting cases that you presented there. Any questions from the floor? Do you seek any clarifications from what he has presented? But thank you so much. If you have any questions, do you mind posting them on the chat if you are not able to speak? Otherwise, I will assume that either we all understood or we all got confused. It's possible. Syndromes are never easy to deal with, genetic syndromes. All right, so thank you so much, Dr. Dzveya. I think this is very interesting, and we want to continue in this same spirit, whereby our trainees will go in detail and try to work out what the syndromes are or the multiple defects that we encounter. Otherwise, thank you. Well done, Dr. Dzveya. And I think the team enjoyed your time with us, and maybe they'll look forward to seeing you in the future. But thank you so much for the effort you've made, for taking time to go through the OMIM. We just want to let you know that we'll be having a refresher course this year. But instead of the usual refresher course, this particular refresher course will be physical, and it will be hosted at the Zima House. The refresher course is on prenatal screening and diagnosis, where we are trying to teach the wider community, that includes midwives, general practitioners, and obstetricians, on prenatal screening and diagnosis methods for various conditions, from preeclampsia to aneuploidy to multiple defects, complications, and to preterm birth screening. So we should draft a rota over the weekend. The meeting is on the 3rd. I think Thomas should share a post in the group. I'm not sure if the poster was shared in the group, but Thomas will share a poster of the meeting. Is there in May, on the 3rd of May, 3rd or 5th of May, I'm not sure. but Thelma will share the poster. So we're going to come up with a proposed program. We'll ask you guys, those who have presented in certain areas, we just ask you to go through your presentations again in this meeting. Is the 4th of May. It will be on a Saturday, physical meeting at the Zima House, and we expect all of you guys to attend in person. So in this particular meeting, because we are addressing general practitioners, we are addressing midwives, and we are addressing obstetricians and gynecologists. So try to make your presentation as much understandable as possible to simplify it to a level where somebody who is not in the field can understand you. So we'll ask you to just do your common presentation. Those who have been doing twins, we'll ask you to present on twins. Those who have been doing preterm birth, we'll ask you to present on preterm birth. The same applies to those who have been presenting on aneuploidy and fetal defects, and also preeclampsia. So we'll kindly ask for you to present at this particular meeting. I think by Monday, we should have a tentative program on how the day will go, but it's more likely to be a whole day program, because it's more like a workshop where we just want to interact with everyone, to give people ample time to ask questions on whatever has been presented. The presentations for now, we will table them for 30 minutes, followed by 20 minutes of questions. So yeah, you'll have enough time to explain to people what you'll be trying to teach them. So yeah, I think that's the announcement. I don't know if there are any other questions or any issue that people will need clarification on. Just to let you know that the UZ fetal medicine unit is ongoing. Patients are being scanned at ANC Parignatwa. So remember this. Otherwise, enjoy the rest of your day, and bye-bye.